We are live now, doctor.
Okay. So, good evening, everyone. This is the third episode of second season, and I welcome you all. I'll just tell the rules once again what we are going to do in this. So this will be a 5 minute presentation by three presenters in this episode as well, and then there will be war councils. We have two constant superhero councils, Dr. Kaushik Tripathi and Dr. Divakant Mishra, who has been there since the start, and we have a senior faculty, Dr. Soumya Seth, joining from Mumbai. So, Dr. Soumya will be giving 20 points for each candidate out of 20 and 10 for Dr. Kaushik and Dr. Divakant. And today we have three very good presenters, Dr. Sarang from Lucknow, Dr. Giriraj Vibhote from Hubli, and uh, one more we have. He's there.
Dr. Arjun.
Yeah, he's there. He's not there yet.
Yes, he's there.
Yeah,
He's there. He's there.
Yeah, Dr. Arjun from Baroda. Hi, Arjun. Hi. So, so we have three good speakers, and we have two intravitreal armamentarium also after this, Dr. Pallavi and Dr. Rajshree. And there will be the very important part of this, that there will be audience polls between the war and the intravitreal talk. So please stay, everyone, and then you can actually make your winner out of that. So welcome everyone. I think we can start the show. Dr. Nikita will be moderating and I'll be doing the support along with Dr. Dipanshu.
Sorry to correct Karthikeya. For the
Dr.
intravitreal talk, we
Richa.
have Dr. Richa and Dr. Rajshree.
Yeah. Dr. Richard.
It's okay. It's okay.
It's okay, Karthik.
Yeah, let's start with the first warrior. Dr. Giriraj will be presenting on a gentle tool, a powerful outcome, RD Saga. Dr. Giriraj, over to you, please.
Thank you. Thank you, YOSI and the team and everyone for this opportunity. I'll be sharing the screen. So a gentle tool, a powerful outcome. This is the story of a RD. So you are there on a Monday, you feel, okay, there are so many patients in my OPD, but I have to do an RD surgery also before I can attend all these patients. But luckily, it's a simple retinal detachment surgery for you. It's a pseudophakic single superotemporal hole RRD case. So you thought, I am in the safe place, I can finish it fast and go back. I couldn't be at a better place than this.
सब कुछ कंट्रोल में है रॉय सर हम इस वक्त भारत के सबसे सुरक्षित जगह पर
But the fate has another plans. There was sudden compressor failure and the globe went into hypotony, but somehow you still struggled and somehow settled the retina, and you are happy that you could settle the retina, but you see this the next day, there is a huge subretinal PFO bubble. In fact, it's a very large bubble. You wait for a week, but it is not going to go anywhere. You have to do it. So there comes the gentle tool, the hero of today's session, that is the 41 gauge needle. You aspirate the PFO bubble and you hope that, okay, now you have conquered the problem and bach gaya. But retina has its own ways to make things complicated. Now, after the removal of PFO, you see that there is a fold. Because of the extra retinal tissue, there is a foveal fold. And now what will you do? So now we go back to our hero for today, that is the 41 gauge needle. You inject subretinal BSS superior, temporal and inferior to the fold, achieving macular detachment. You make sure that your BSS is spreading all around your fold. And then you do fluid air exchange and gas tamponade was given. While doing fluid air exchange, we make sure that the fluid is reaching till your fold. And then gas tamponade was given and positioning was told to the patient. And 1 week later only you can see a well-settled retina. And 1 month later, this is the picture with BCVA improving to 20/10. So I thought I'll maintain social distancing from such issues from now onwards, but somehow
तुम में से पहले मरना कौन चाहता है
this happens.
पता नहीं ऐसे डेंजरस सिचुएशन में मैं ऑटोमेटिकली आगे कैसे आ जाता हूँ?
So this was another patient who was operated for traumatic RD 3 years ago somewhere else. But he decided that after 3 years, he came to me with this kind of picture. There was emulsified oil in the AC. I did the AC wash, then injected a little trypan blue. You could see the beautiful intraocular aurora borealis here. And then I did the AC wash again, and then used the visco to remove rest of this emulsified oil from the AC. You could see the fibrosed anterior capsule here for the cataract. I made the main entry and tried to use the cystitome to start the rhexis, but it was of no use. So I had to use the capsulorhexis forceps and then scissors to somehow complete the rhexis. Then the cataract was soft, so luckily we did not need to use any phaco for this. Then we are going in with the 25 gauge vitrectomy system. And I started removing the emulsified silicone oil, and as soon as I go in, I see this. There is a large membrane involving the disc, involving the macula, even the nasal area, covering entire the posterior pole. So now what I try to do is I gently try to hold the membrane and try to separate it slowly from the disc to get any plane for dissection. So now I could successfully get the plane. Now I grasp and regrasp the membrane again and again, slowly removing it from the retina, making sure that I'm not exerting too much of a pressure on the retina, and successfully I could remove it in toto. Then I stain the rest of the macula with BBG to see if I could do ILM peel because of the macular pucker. But as we can see, the ILM has come out along with the epiretinal membrane. So lessons from the previous case, I use the 41 gauge needle, inject subretinal BSS solution and cause macular detachment induction, give retina some room. As I have done this only 5 days back, I don't have the post-op yet, and I'm hoping all will be well and keeping fingers crossed. Thank you. I hope I'm in time.
Thank you, Dr. Giriraj. You were well in time and very interesting and very challenging cases. Truly, you are a retinal warrior. Let's have Dr. Somil Sheth for his expert opinions.
Yeah, hi. Hi, Nikita.
Yes, sir. Hi, sir.
I'm in a little bit of a poor reception area because I've just got out of my parking. Can I reconnect again in the next 5 minutes?
Yes,
If it is
sir.
okay with you?
Meanwhile, we'll have, yes, sir. Meanwhile, we'll have Dr. Divakant, sir, for his
Sure,
comments.
sure. Please go ahead with
Yeah,
him till
yeah,
then.
yeah. Okay,
Okay.
sir. Okay.
Bye.
Thank you so much, Dr. Giriraj. Excellent. I mean, a technique and the way you did it. Can you walk us through your first case once again? We don't need the video. The technique, because I could see that you induced a redetachment
Yes,
and
sir.
injected fluid.
Yeah.
I think in the first case, it did not came up to the fold, is it? Or
Initially, it did not come up to the fold, sir. But while fluid air exchange, we made sure as you do fluid air exchange, as you reach the disc, the fluid starts coming towards the fold. In the first case, we injected it little away from the macula, and 3 places we injected and created localized blisters. And as we did the fluid air exchange, once the air starts filling, the fluid comes into the macula and detaches the macula.
right, perfect. So you were able to achieve that at the end of your fluid air exchange, right?
Yeah, sir. Yeah.
Correct. And did you consider using, say, a scraper or something, to release these folds mechanically?
Uh, in this particular case, I did not try it, sir, because it was a foveal fold and I did not see any space where it could settle.
Okay.
So we needed some space for it to fall back.
And okay. And while injecting, what is your preferred technique? Do you do it by hand or use your while injecting the fluid? What is your
No, sir. We have that cannula and we connect it to the silicone oil injection system with 20 pressure. We slowly inject it.
perfect? Excellent, excellent. Very
Yes.
nice.
Thank you, sir.
Thank you. Yeah.
Dr. Kaushik, sir?
Dr. Giriraj, what happened to the PFCL bubble? I did not get it. Like you just induced the macular detachment and like what happened to the PFCL bubble?
So initially it was a large PFCL bubble, sir. So first thing which we did was aspirate the PFCL bubble with 41 gauge needle. Once that entire PFCL was aspirated, then because there was empty space, the fold formed. So then we dealt with the fold. So PFCL we removed first as a first step. Then we dealt with the fold.
So you are, yeah.
Yes, I'm done. Dr. Nikita, please.
If I may, if anybody else to the Vice Council, what would you do in the second case where there was a large pucker involving the macula? Would you anything else would you do? ILM was not there, and I could think of only this.
Yes, I mean, I think this worked for you. I might have just injected gas and seen for some time how this works out, and go in again if this persists. But I think you did a good job.
Yes.
My approach initially probably would have been to just inject gas and see for some time.
Okay.
So,
Yeah.
can I interrupt?
Somil sir is back.
Sure.
Yeah, please.
Yes, yes.
Yeah. So I agree with Divakant. Even I would have just injected a gas bubble without going subretinal in the first go. In the first case, just
Okay.
peeled off the ERM.
Yeah.
In the second case, sorry. In the
Yeah.
first case, probably
Uh-huh.
what I would have done, see, that is a very large PFO bubble. And if
Yeah.
you are aspirating it directly with a 41 gauge, you're going too close to the fovea.
Yeah.
And there is every likelihood that you're going to incur a fold.
Okay.
Probably what I would have done is created a blister around right in the beginning itself. And then
Uh-huh.
the PF and would have connected that blister with the PFO bubble. That way,
Okay.
the PFO bubble would have sunk down a little bit because of gravity, and
Uh-huh.
then probably removed it with a 41 gauge needle in a much bigger, better parafoveal area rather than going right near the fovea. So
Yes, sir.
that could have been one approach, but otherwise, it was very well managed. I mean,
Nice,
you
sir.
didn't anticipate it that you'll get that big a fold, but it's like it could be expected. So I mean, you can't choose much in this case, but
Yes.
this could have been an alternative approach.
Yes, sir. By doing that, by injecting the BSS initially, do you expect any chances of the PFCL bubble forming multiple bubbles and then you have to
Could
poke
be.
at multiple places?
Not really.
Okay.
I don't think it'll form multiple bubbles.
Okay, sir.
But even if it does form multiple bubbles, they would be moving, right? So you
Yeah,
don't
yeah.
need to poke in. They would not be compartmentalized.
Okay, sir. Yeah.
And we can use more PFCL to push those bubbles and,
Yeah, yeah.
Correct.
Okay. Yes.
So that is one alternative approach. Otherwise, it was really well managed.
Yes, sir. Thank you.
Thank you, Dr. Somil, for that expert comment on that. All good. I agree with the alternate advice as well. And thank you, Dr. Giriraj, once again. We'll move on to the next presentation by Dr. Sarang Hansraj. He'll be presenting on wet buccal peel and massage. Dr. Sarang, please share your slides.
Hello everyone, thank you YOSI for this opportunity. I'll just share my screen. Should I start?
Yes, please go ahead.
All right, thank you.
Hello everyone. Actually presenting the management of a challenging case in which a gentleman presented with decreased vision in the left eye. The patient had avascular peripheral retina in both the eyes, along with a vasoproliferative tumor and a large macular hole with intact basilar layer in the left eye. Both the eyes were first lasered and then the left eye underwent vitrectomy. The muscles were tagged and the vasoproliferative tumor underwent double freeze-thaw cryotherapy under direct visualization. A 42 band encircling silicon belt was then placed in the eye. Gauge pars plana vitrectomy was then started. The posterior hyaloid was gently lifted and separated from the retina. And maximum peripheral vitreous removed in a safe manner. The retina was then stained under air and the ILM was peeled. Multiple ILM flaps were created and peeled up to the edge of the macular hole. But then disaster struck. All the flaps dislocated right at the end. To our horror, we couldn't place the ILM flaps over the macular hole even under PFCL. We then pivoted, completed the peripheral vitrectomy, did additional laser to the avascular retina, and did gentle massage with a soft tip silicone cannula around the macular hole. A very thorough fluid air exchange was then performed. And 20% SF6 gas injected. The patient did well post-operatively with a closed macular hole, improvement in his vision, reduction in the vasoproliferative tumor, and stable FEVR in both eyes.
Thank you, Dr. Saran. Can I just ask you a question? What was the age of the patient, Hanson?
20-year-old.
Okay, and what was the size of the macular hole?
It was 675 microns.
Okay, so ultimately you just massage the macular hole edges and close, right?
Yeah, so my approach generally, when it's more than 500, I'd like to put flaps. And when I lost the flaps, I wanted an alternative. The patient didn't, I mean, obviously, no one wants another repeat surgery. So, in a as gentle, atraumatic manner as possible, I just mobilized the retinal edges and the holes, edges of the macular hole.
Comes to show that peeling, putting a flap is not always necessary, I believe. Okay, we'll have the comments from Dr. Somil, sir.
Yeah, again, well managed. About the macular hole, I believe that if it's a large macular hole, there should be a flap. If you've lost a flap, you can always take a free ILM from somewhere and stuff it into the hole. That would be my approach in this case. What I'm intrigued is a 20-year-old guy with an FEVR with a VPRT. So I do not really know. I don't think you showed it in your surgery, or maybe I missed it. How you did manage the vitreous base part? Because there is an abnormal vitreoretinal adhesion all throughout, especially at the area of the VPRT and near the edge of the avascular retina, which is well beyond the base. So if you got away with just putting in gas in a case like this, I really don't know how you manage the peripheral vitreous so very seamlessly, considering it's a 20-year-old. You did induce a good PVD from the disc, but then how the PVD got managed right up to the periphery, I couldn't see it. So or probably I missed it.
So actually, sir, I was also of the same opinion that I will not be able to manage the peripheral vitreous. And also I'll be doing cryo to the tumor, which may induce a break additionally. So that's why I put a belt and that to a 42 instead of a 240 band. Hopefully that takes care of the peripheral vitreous.
No, how far back were you able to get the vitreous off the retina?
I went up right up to the indentation caused with the belt.
Okay, and you didn't find any abnormal attachment before at the junction of, let's say, the vascular and avascular retina, which could have been well, before even you reach the buccal indent.
So there was one area like that. Actually, in the video, it shows also that so I was very careful around that area. I also did a bit of extra barrage kind of a laser also in a suspicious area. There was no break there, but I just thought intraoperatively that that is one area to be careful of.
Okay, and you didn't have to do any laser to the VPRT, it was just cryo treatment.
So I lasered 1 month prior. So the objective of that was to maybe it helps reduce the exudation vascularity of the tumor. Also helps me achieve lens sparing peripheral laser, and therefore vitrectomy becomes better. And then I did cryo additionally onto the tumor. So this 1 month gap, then additional cryo, I think it's helped reduce the tumor.
There was no localized attachment anywhere, right? Exudative or otherwise.
None, sir.
So about the buckle thing, I don't know. I would like to ask the group per se whether everyone would agree putting the buckle in the first place. I mean, didn't you feel that you could have done without the buckle? Because if the vitreous was not detached, right? I mean, it was not detached even way before you reach the buckle indent. Did it really actually serve a purpose?
I felt so that he's only 20 years old now. We don't know how long term how the eye will progress. It's the FEVR eye. Even the vitreous is pathological in these cases.
Correct.
So, and I'm doing cryo to the tumor additionally, which is another one more thing which can induce a break. If there's no RD now, it may lead to an RD in a vitrectomized or a partially vitrectomized eye. So I felt it's better, a more prudent approach to actually safeguard against all of these things.
Okay, you never felt like putting the buckle a little bit belt you put, right? 240. A little bit
Well,
42.
more retro place than what you actually, where you actually put it.
so I measured the tumor and I placed a 42 band, and as per the measurement, so that the entire tumor is indented, that was
Oh,
my placement of the belt.
okay, fair enough. Over to the others.
Dr. Kaushik sir, would you have done anything different?
Yes, I would try ILM from some other place. So I would have definitely tried that. And even if it was lost, this is the last option. Yes, but it closed nicely. And I think because this is a very young male, I would have also gone for this buckle at least such a 240 belt. But very nicely managed. Yes.
Thank you, sir.
Okay, so we have one placing a buckle, one not placing a buckle, and Dr. Devakant sir.
Yeah, so very interesting case, Sarang. So, and nicely managed. Buckle, I would not have put in the first place. But yeah, I think what Sarang is also saying, it makes sense as well. Young patient, long-term cryo, and all these things, and these VPTs can behave strangely at times. So there's no flip side to it. Also, I feel it's a good approach. And what Dr. Kaushik also said, I would have looked for more flaps. Were there flaps available nearby, Sarang, which we could have had used?
No, sir. Actually, I had completely peeled the entire macula, and I had actually tried my flaps which dislocated. I tried placing them. Once
Hmm.
they were not working, then my mind went to what other options do I have?
So again, in my most of my cases, number one, I keep my flaps smaller. And again, I keep at least a wedge of my flap, remaining for maybe a secondary surgery or, if something like that happens. So I make really tiny flaps which just cover the hole and then do another layer of peeling if needed for these cases. Anyway, excellently managed, and we could see that very nice results. So very good done. Yeah.
Thank you, sir.
And Dr.
Yeah.
Saran have used a temporal flap also. Just do a temporal. This time you lost everything, no? So you just do a temporal part and you just put it over the macular hole, and it would have definitely closed. And because it is just temporal part, your nasal ILM is still there. So I have never lost this while doing temporal flap. Just a temporal part of the like temporal part of the ILM, put it over the macula itself, and it will close.
Yes, sir. Definitely. Thank you, sir. Yeah.
Again, a lot of
Kaushik,
Loss was like because you did like flower petal like thing, and you did a very large kept a very large amount of ILM, which actually once and also you do not go very near the macular hole till it is at the final stage. So if you peel it toward till the macular hole, that's just the margin of the macular hole, then the attachment is very fragile and it will go off. So keep a
Uh,
little around some part of ILM should be around the macular hole should be attached till the last part. Otherwise, you will lose this.
yes, sir.
A- And
Yes.
also maybe the vacuum could be kept a little lower while trimming the flaps. I think Dr. Devakant has something to add.
I was just asking Dr. Kaushik, how has his experience been, and the panel as well, with temporal flaps. I switched briefly to temporal flaps, and for the first time in my life, I had some failures in my surgeries, irrespective of the size of the hole. So I switched back again to something what Sarang has shown. So what has been the experience of panel if others are using a temporal flap?
No, my like yes, Soumil sir, please.
Yeah, in continuation with the same question, you may make a temporal flap, but do you even peel off the ILM in the nasal area? Let's say you peel it off and then just keep the temporal flap, that should be all right. But leaving the entire ILM in the nasal area and the macular bundle area would just relieve traction just one-sided, right?
Dr.
But
Kaushik.
ultimately, if your goal close the hole, then it's done. Most of the time, it will close.
Probably in
And
this case, we needed this approach also to get rid of a lot of ILM.
So you routinely, Dr. Kaushik, do you routinely just make a temporal flap and leave all the nasal ILM intact?
currently, I am doing like that only, and even the large holes also close. So most important thing is there should be like the fluid air exchange. It should like the fluid should not be there in the nasal part of the fovea, and the flap should not go out. And if you like immediately after surgery, I place the patient that like uh, that's the part of the eye. He should be at least on the other side of like if it is right eye, then left lateral, the patient should be shifted. And most of the time, it stays that side and it closes. So I think it is a worth a try if people are not doing, and even large holes can close.
For that, I think drying थोड़ा ज़्यादा करना है. मतलब
Ah,
the
drying
point of that is that it will take at least 5 to 7 minutes or maybe 10 minutes for you to make it dry completely. And if you actually want to do temporal flaps. So I also did some temporal flaps recently and I saw failures. And then I realized that it was not actually very dry, and that's how it was not very stuck to that point. So in two of the cases, I did a lot of drying, but then it used to take me only 10 minutes to do a macular hole surgery. Now 10 minutes of drying, so I stopped doing.
That's the problem.
How to inject the gas, Karthik?
See,
Uh,
I relooked
Like
at my failed cases, and this was my observation as well. And drying is a very irritating thing. I mean,
Yeah.
you need to spend so much of time, and fluids keep coming again. So for lazy surgeons like us, probably the this technique works better.
I think drying in is an issue. And so, Kaushik sir, how long do you keep the patient in that position for?
no. Actually, what I do is like previously I used to do like the injection of gas was blind, but currently what I do is when I am inside and the like I use contact procedure, contact lenses are there. In the meantime, the assistant changes the fluid air exchange gas to the SF6. So while I am in view, so when I am closing it, I am still seeing the retina. So I do not give 5 to 10 minutes time. I just make sure that the nasal part of the retina and disc is dry, and then after I close, I immediately put the patient like on the other side. And by that, I have seen like touch wood, none of my cases are failed till now.
Great, sir. The under visualization gas, this can be tried, sir.
Yes, under visualization, you just like tell them you can see, because there is a contact lens. Once the IOP gets low, the visibility will reduce. So you tell them to put it and inject it full, and you are seeing that flap is there in the in the over the fovea, and after that I only just change the posture so that the fluid doesn't go back to the fovea.
Right, sir. And Dr. Sarang, was there a small PFO bubble juxtafoveal in the end? I saw on the OCT.
Yes, I also saw that.
I
Also,
think there were multiple bubbles when you were doing FAE. I think one of them got trapped near the hole. Is it?
No, I think that's just an artifact. It's not come in any other scan. All the bubbles are aspirated very carefully while doing the last drying fluid air exchange.
Okay.
Okay, I think thank you, Dr. Sarang, and everyone for the expert comments. Now we can move on to the last presentation by Dr. Arjun Desai. He'll be presenting When Chaos Knocks. Arjun, over to you.
Yeah, thank you. I'll just share my screen. Is my screen visible?
Not yet. Yes, it is.
Okay, good evening, everyone. At the outset, I'd like to thank YOSI and the Retina Focus Group for hosting this wonderful platform where young surgeons can interact and learn from each other. And the title of my presentation is When Chaos Knocks. And I'd like to start by just throwing out this quote by Albert Einstein. As retina surgeons, we are at the top of the ophthalmic surgical food chain. The buck stops with us. We can't suture the wound and refer it to someone else. We just have to make everything right and carry on. So let's see what happens when chaos knocks.
Is there an audio? We can't hear anything.
Yeah, the audio is playing.
No, I don't think we can hear anything.
Yeah, no audio.
Now,
No.
should I just directly play the video?
Yeah, you can speak, Doctor. Yeah.
Now, is it audible?
No.
Okay, should I just speak?
Yeah, please.
Yeah, please go ahead.
Yeah, so apologies for that glitch. So this, I'll just start the video. So this first case is a case of a epiretinal membrane removal in a 68-year-old male who's pseudophakic and has undergone barrage laser for lattices in both his eyes. And this is a routine case. Here the PVD is being induced. You see that there after the vitrectomy is completed. The ILM is stained with BBG, and ILM peeling forceps are used to remove the ERM there. It comes off pretty easily. It comes off in toto. It's a straightforward case going pretty well. But of course, there's more to this case. And you see there that there's a streak of red across the macula. And unfortunately, there those forceps have struck the retina. And there's a large inferior break and a massive choroidal bleed. And I increase the infusion pressure to 60, wait for some time. Then I go with the flute needle and try to aspirate that clot, but that's unsuccessful. And I shift to air now. And under air, you see that there's a large clot on the posterior pole there. I try to tease this clot away with the cutter, and I'm gently teasing it away. And as I move it away, I then start to aspirate it with the cutter, and the clot there is then aspirated, and we go back to then that inferior large choroidal mound and break, and we dry it with the flute needle, and we now go to laser, and continuous laser is applied on that bleeding choroidal area, and interrupted laser is applied around the break, and we now go to inject silicone oil after drying the break and the macula, and silicone oil injection is now done. And after this, you see that at 12 weeks, the retina is attached and the heme has cleared. And after oil removal, also, this patient has a good outcome anatomically as well as visually. This next case here is a case of a closed funnel retinal detachment. It's a closed funnel with napkin ring constriction. The retina is pulled up anteriorly, you see there, and you see some air bubbles in the vitreous cavity there, which indicate that the infusion cannula is in the right place. And I proceed with the vitrectomy there. I release all the vitreous adhesions bit by bit. And ultimately, that last star fold there is grasped with the forceps, and this last star fold gets released, and after this last star fold is released, the retina is much more mobile now. And I go to do a fluid air exchange, but unfortunately, the cannula has slipped in all these uh, maneuvers, and there's a massive retinal detachment with subretinal air. I have to make a drainage retinotomy now to drain this air. I aspirate this air out, and you see there I'm going there with the flute needle, and this air comes out. I again recheck the position of the infusion cannula under visualization. I also go with a cutter, see that there's a metal to metal touch, that there's no vitreous around it or no retina around that cannula. So the cannula is well in the vitreous cavity. You see the mobile retina there just fluttering behind the cannula. And I again start the fluid air exchange. It starts off well initially, but then again, unfortunately, the cannula just slips back in and there's subretinal air. And at this point, I decide that I'll just place the infusion at a different place and go ahead with the surgery. And now the fluid air exchange is going on and the retina is settling. And that there is a drainage retinotomy which I'd made to drain the air, and luckily it's come nicely on the belt indent, and the retina is nicely opened up. You see those two superior breaks there. The inferior drainage retinotomy and breaks are lasered. The fluid air exchange is completed, and we inject oil. And on the first day post-operatively, you see there that the funnel is open. So that's all from my side for when chaos knocks. Uh, Thank you, everyone.
Great cases, Dr. Arjun. May I ask, in the first case, when the choroidal happened, why did it actually happen? Did you go out and check where is the infusion cannula?
Sorry, your voice just got cut out. In the first case you're talking about, or the
In the
second case?
first case, also CD happened, no? Choroidal happened.
Yeah,
So
so in
did
the
you?
first case, that was traumatic. I think my assistant was happy that the case is getting over. He decided to move the trolley and pushed me in the process. So it was an actual physical push, and the forceps hit the retina. So it was a hemorrhagic CD there.
Okay. Dr. Somil, sir, would you like to
Yeah.
comment?
Yeah, in both the cases, why didn't you opt for using PFO here? It would have made life much lesser complicated in both the cases.
Yeah.
So
Yeah.
I feel that was one absolute indication for using PFO. But overall, yes, I mean, you did manage the case very well. In the first case, yes, what I think was pointed out was you should have checked the cannula with whether it still remained in the correct place, which it did because the choroidal mount didn't increase much. It increased hemorrhagically up to a certain point, and then it was all good. So the first case, I think that heme at the macula that got accumulated when you were doing that air fluid exchange, or maybe while doing surgery, could have been avoided because it can lead to a lot of problems later on, even while removing it or later on in the post-operative. But PFO is the safest way of preventing that. Any bleeding episode in the vitreous cavity which happens all of a sudden, which is going to compromise a very clean vitrectomy. This patient had a potential to improve to 6.6. It did improve to 6.9 eventually, but PFO should come to your mind in the first go. As far as the second case is concerned, uh, the reason you said that the cannula kept slipping, it's not like that. When the retina balloons, usually the infusion sometimes it can go behind very often. So I mean, in that case, PFO, I mean, it's a no-brainer. You should have used. But the other way I would have handled probably is also kept an AC maintainer. AC maintainer ensures that you are no way going to go under the retina. Even though the inferior retinotomy was on the buccal, for me, making an inferior drainage retinotomy is a no-go. I mean, I wouldn't make it in any case, buccal or not, because that is the cause for PVR and that is the place where most of the retina start detaching or puckering in the post-op period. So I don't know whether the drainage retinotomy was made deliberately or it was a break that you utilized to drain the fluid there.
No, no, I made the drainage retinotomy to get rid of the air because the air was migrating anteriorly. So I made it ballooned up. So I made the DR to get rid of the air there.
Correct. So
You are
what when the cannula slipped in the subretinal space, all you needed to do was put an AC maintainer and leave the cannula open. All the air would have escaped from there by a simple subretinal drainage. And positive pressure of the AC maintainer would have kept the fluid inside on top of the retina rather than underneath. And also PFO would have done the same trick. Even if you did have to make a retinotomy, definitely it wouldn't have been inferior. Yours was like at 6 o'clock position. It was lucky that you had it on the buckle, but I think I would have made the retinotomy. If so, if I would have made one somewhere else. That would be just my take on this. Otherwise, yes, in the end, well managed. And as you said, the retina surgeons are on the top of the food chain. it's a though we may face a lot of mayhem, it is still better to be on the top of the food chain rather than at the bottom. So very well put there. Thanks, Arjun.
Thank you, sir.
Points well made, sir. Over to Dr. Divakant, sir, for his comments.
Yes, similar thoughts, Dr. Arjun. What sir said, particularly in the second case, I would have started using PFO a lot earlier, as you are unfolding things. So it takes care of a lot of things. And what Somil sir said about keeping, just a sec, about sir said about keeping the infusion open, that also works beautifully. Uh, Either way, see, a lot of things are
Emergency services.
sorry, just yeah, sorry. So a lot of things we are sitting here with a cool mind, so we can comment very easily. But the point of you presenting such a case is so that all of us can think about such things, and when this happens to us, we can work in a better way. So thank you so much for picking such cases so that all of us can learn more. Great cases.
Thank you
Thank
for
you.
the point.
Yeah.
Finally, Dr. Kaushik, sir.
Thanks,
I hope
Arun.
ASG bias now during the marking.
Nahi,
Okay.
it is better that I like do not vote for like do not give marks for Dr. Arjun.
Oh, it's all right.
My suggestions would be like Arjun, definitely I would have checked the infusion even after this supracortical happened. And
Hmm.
why do you want to like take out the blood? It is like not a good idea to take out the blood, like supracortical
So,
blood from this thing. That is not a good idea. You do not go there. You will go there, you will cause more problems. So problem point is I have to close it as early as possible. And as Dr. Shomil sir said, it is better if you are seeing that it is losing, it is better to put a PFCL, and PFCL itself causes a little amount of like IOP rise. And if you can keep the IOP elevated for certain time, then definitely the bleed will close. So that is our target. And in the second part also, the infusion, yes, I would have definitely used like anterior segment to get the infusion and put a PFCL bubble. It will help you see the PVR also where you need to dissect, and the surgery would have been made much easier. But yes, we do not usually show such difficult cases in the like large media, and these are cases from which actually we learn. So this supracortical hemorrhage could have gone to be much worse if like it was not managed properly, but you managed very well. Yes, if such things happen, you have to make sure that in infusion is inside, and definitely what I would have done is I would have just increased the pressure to 80 or 100 even, and then see what happens. Like just stop and see. First, obviously make sure if the infusion is in the vitreous only. If because it is supracortical hemorrhage, the choroid will detach and the cannula itself can go under the choroid. Then even if you increase the IOP, then it will increase the supracortical like detachment. That is another thing. And definitely do not try to drain it in the first sitting, because book also writes and our experience is that also it doesn't come out and it creates more problem than is necessary. So
thank you, sir.
yes, very nicely managed, and definitely try to use PFCL in such cases. So sometimes what happens now, the blood will clot in the just again it will come to the disc and it will create a thick like thick mass kind of thing in front of the
Hmm.
disc. So, and visibility is poor. You are not able to clear anything, and like you are just puzzled what to do. So it was a difficult scenario, but you managed well, and finally it went well. That is what matters.
Thank you, Kaushik, sir. And I think very well managed, Arjun. The chaos was managed very well. And over to you, Karthikeya, for the voting.
Dr. Dipanshu, should we take the voting now?
Yeah, I think we can make Manjula ma'am, if you can make the voting live.
Okay, doctor.
So we have 3 speakers. I would request everyone to please vote for the best video you liked.
Keep the voting open for everyone.
Can you see the voting happening? Actually, it's not moving on my screen.
Yeah, because you can also vote now, so you will not be able to see.
Seven people need to vote. The rest, I think, all have voted.
And also, Arjun, there is no need to drain the subretinal layer bubble. So it would have definitely gone out once you have increased the pressure and because there is already a connection. So another thing is like these closed funnel arteries, they have anterior PVR also. The anteriorly, they are also the ciliary body and the retina is detached. So there is a high chance of getting this sub retinal cannula and also
So,
hypotonic.
so Dr. Kaushik, one more point, if I may add. Now that the break was there inferiorly and it was a close funnel RD, probably you could have even put PFO and left PFO inside for about 10-15 days and then later on exchange with oil. So that would have also helped in, preventing PVR because close funnel RDs PVR very fast here.
Tomil sir, have you used Densiron?
So I've used Densiron a couple of times, not in India, abroad, and I've had a very wonderful experience, very different from what people have actually described. So if there is Densiron is if it's freely available in India, I would like to go back to it. What about you? Have you used it? It's
I've just
available
ordered.
now here, right?
Yeah, I've just ordered 3, so that is why I wanted to take inside because I'm going to plan next week. So I wanted to know because what I read from it that it emulsifies really faster than the usual oil. It emulsifies within 6 weeks or 8 weeks. So that is
No,
what I came across. Have
no
you seen
sooner.
that?
No, sooner than that because it's only 800 centistokes. It's not a very viscous,
Okay.
uh, like silicon oil, which is 1,500. This
Yeah.
is, and the advantage is that it's also easy to remove it because you'd usually use a longer cannula because the last drop goes from the disc. So if you have to have a significant caliber cannula, which is usually 23 or 20 gauge, then you cannot have silicon oil that is highly viscous. I think I can't hear anyone.
Yeah.
So we can hear you. I think Karthike has freezed.
Okay, okay.
Yeah.
So Densiron is I mean, anyone in the group here has used Densiron in India
Not
a whole
yet,
lot?
sir. Not yet, sir.
Sir, I will be receiving my batch in a couple of days. So hopefully in the coming weeks. Yeah.
Sure. So
Got
sometimes I feel leaving short-term PFO is as good as using Densiron,
That's
and it
around.
really helps. The only criteria, I mean, I if it's a phakic eye, I prepare the patient that you'll have to do a cataract surgery compulsorily. And pseudophakic, it's all good to use PFO because PFO causes a lot of debris accumulation just behind the posterior capsule. So cataracts tend to develop really fast in a PFO eye, especially when you've used in a PVR case where you've done like a 360 retinectomy or a close funnel RD like this, which has multiple breaks and anterior pucker or things like that.
Great.
I think,
Is the voting done?
I think
yeah,
these
the
7
voting is
people,
done. Yeah.
maybe we can end the poll. Karthike, do you want to end the poll now? Yeah.
Yes.
Shall we move to the introductory talks, I think? Uh, all right. Thank you, all the presenters. We shall move to the next segment, that is the intravitreal armamentarium. For this, first up, we have Dr. Richa Pyare. Over to you, Dr. Richa, to deliver your talk.
Uh, Good evening, everyone. Can you see my slides?
Yeah,
And is it in?
put it on slide mode. Yeah,
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 great.
good to go.
So, hi everyone. My name is Dr. Richa Pyare. I want to thank Team YOSI for including me in this almost medical intermission in your surgical wars program. I will be talking about case-based insights in managing AMD and more specifically about the role of treat and extend in AMD. So, let's jump right into a case. I don't think my slides are there now. Yeah. So PB was a 67-year-old lady who presented with recent onset drop in vision in her left eye, and on examination, her BCVA was 615 and N18 partial. And on the OCT scan, she had this SHREM with SRF. She was planned for 3 monthly loading doses of ranibizumab and then a treat and extend protocol. And she did really well after the first injection of ranibizumab. Both her vision and structural OCT improved. I continued the anti-VEGF injections, and because the OCT was dry after both the second and the third anti-VEGF, I planned a small extension of 5 weeks. As you can see in the September 22 scan, this did not work out. The SRF returned, and I had to go back to monthly injections. Now, after this, I gave her another 2 doses of monthly injections, and there was significant improvement. In November 22, you can see that the macula was dry. And so again, I attempted an extension at this point. I was able to extend her to 6 weeks, but when I tried extending her to 8 weeks, the SRF record. So we went back to 6 weekly extensions. But here, what happens is after the second 6 weekly injection, the SRF record at 4 weeks itself. So I now decided to switch to aflibercept. After 4 weeks of the first Eylea, the macula was dry. I called her back after another 2 weeks for her second Eylea. And a total of 4 weeks after the second Eylea, again, her macula was dry. At this point, I decided to increase the intervals a little bit. I wanted to plan for a 6 week extension, but the patient had some logistic issues. She turned up 2 weeks late, and we see a recurrence of the SRF. And again, gave her another Eylea, tried the extension again. And at 8 weeks extension, she was doing well. The macula was dry except for some SHREM. So I went ahead and extended her to 10 weeks. A couple of injections later, again, macula was dry, extended to 12 weeks. At this point, I gave her 3 injections at 12 weeks, and she did extremely well as her macula was dry on follow-up at 14 weeks also. And she was maintaining her vision at 6/6 partial with N6. So I decided to exit the protocol and stop the injections Eylea. And this is her follow-up scan when she came recently, 9 months after her last injection. And she remains stable with no fluid, and her BCV is also maintained at 6/6 partial N6. So moving on to the next case, second case is a 79-year-old lady who presented with drop in vision in her left eye. And on examination, there was a peripapillary MNV, and we can see on OCT there was SRF with a flat irregular PD just nasally. So again, I started her with loading doses of ranibizumab, but after 1 month of the fourth monthly injection, the fluid had actually increased. And at this point, I switched her to aflibercept. 4 weeks after the Eylea injection, it was dry. We increased the interval to 6 weeks. Again, this patient, instead of coming up after 6 weeks of the sixth week injection, came back after 8 weeks. And it essentially became like a forced 8 week extension. But as you can see, the macula was still dry. So I extended her by another 2 weeks to bring the extension to a total of 10 weeks. The patient then followed up 2.5 months after this injection. So then again, I could make out some amount of fluid here, and I gave her another injection Eylea. Now, after this point, 4 months after the last injection, she was still dry. So we decided to stop the injections and observe. And this is again her picture when she last came, about 10 months after her last Eylea. And her macula is still dry, and she's maintaining 6/6 with N6 vision. What about in PCV? So Mrs. Kusumlata was an 83-year-old who had presented with complaints of distortion in both eyes. The right eye had distortion for many years. This was a right eye picture. And in the left eye, she had noticed it for the past 15 days. And this was the OCT where she had multiple hemorrhagic PEDs. There was subretinal heme and there was subretinal fluid. She was planned directly for 3 loading doses of aflibercept. She got her first 2 doses on time at 4 weeks. But there were some health issues and she got lost to follow up, and a third injection was at 8 weeks. Despite this extension, the response to the injections was excellent. Her BCVA improved from 624 N36 to 6/6 N6. At this point, again, she was lost to follow up because of her health issues. One final case before I close. PJ is a 55-year-old male who has been treated for CSR in the past, and he presents with recent onset distortion in his right eye. As we can see on the OCT-B scan, there's a large pachyvessel just underneath flat irregular PD with some SRF, and the OCT-A scan shows very beautifully a neovascular network. So this was a typical case of PNB. He actually got 6 injection aflibercepts, and then his macula was dry. Vision was 6.6 N5, and for a year he did not need any more injections. His vision was maintained. The macula was again dry, but the network size increased on after about a year. Still, there was no fluid. We held off on therapy. Almost 7-8 months after that, we could make out some fluid again. The network was active. Again, we started him on aflibercept, but at this kind of second round, we could only extend him up to a maximum of 10 weeks. So he continues to receive injections every 10 weeks, and his vision is 6.9 and 6. So why treat and extend? We know that treat and extend can optimize for the number of visits and maintain the visual gains of fixed monthly and bi-monthly dosing. And why aflibercept? Because we do have some data that backs what we practically saw in our cases, that aflibercept can give us a longer treatment extension than ranibizumab. There's a network meta-analysis which has shown that treat and extend using ranibizumab and aflibercept. They've compared the two and concluded that patients on aflibercept require 6 fewer injections when compared to the patients on ranibizumab. So this is my take-home message. We all know now that treat and extend is the standard of care for neovascular AMD and PCV worldwide. It is easy to implement. It helps reduce the number of clinic visits and ultimately the treatment burden on the patient. It is important to understand that every patient will have an individual maximal fluid-free period, and the treating retinologist needs to determine that, and they should be proactively injecting to prevent the fluid coming in and to optimize the visual gains. And there is a misconception among a lot of AMD and PCV patients that 3 loading doses are somehow a treatment course. And once that's completed, they need not have any further injections. And we should very clearly and upfront explain to the patient that they will definitely need more than 3 injections. And you have to keep them in the loop. You have to explain your treatment decisions to them, and the importance of treat and extend as opposed to dose and ditch. These are my acknowledgements. Thank you very much. I'll hand the screen back to Dr. Dipanshu.
Thank you, Dr. Richa. Very quickly, you went through all the cases. Nicely presented cases, nicely documented as well. I would
Thank
like to
you.
now open the discussion to the panelists. Dr. Somil sir's comments, please, on the cases that were
Yeah,
discussed.
yeah, hi, hi. Very nicely demonstrated, actually, Dr. Richa. Most of the cases were very well managed. What I would, I mean, I'm telling you what I do in my routine practice. I'm not that much
Yes,
of
sir.
a medical retina fan, but my usual treat and extend, whenever I'm trying to extend anything, I use
Yes, sir.
aflibercept. If I've used ranibizumab for the first 3, automatically the 4th injection will be aflibercept if I'm giving it at 6 weeks. If I'm
Right.
making 6 weeks into 8 weeks, again that injection would
Mhm.
be aflibercept. I can come back to ranibizumab and can maintain that 6 weekly until the thing recurs. If it recurs, then you go back to 4 weeks. That 4 weekly then would become aflibercept again. I maintain it with ranibizumab, and I'm making that 4 into 6 weeks again. I'll use aflibercept. So why strategically, whenever I'm extending an interval, I use aflibercept for 3 reasons. One is obviously you said that the duration of action is longer. So for extend, yes. Secondly, to prevent tachyphylaxis, the body has got used to one molecule all the time. You've injected multiple, you're just giving it a little bit of a switch. And third, the most of the choroidal neovascularizations are not very, distinct pathology wise. They, they could be a mixture of, having a great deal of a PCV component, where aflibercept works much better than ranibizumab. So for me, extension is always done with another molecule, usually of a longer duration, which is usually aflibercept. Today we have more second generation anti-VEGFs in our armamentarium to try those out as well. As far as PCV cases are concerned, yes, my first line of therapy would be aflibercept if the patient can afford it. Now we have biosimilars of aflibercept, so definitely, if they're as affordable as what ranibizumab is. So for PCV, it's a straight go ahead with aflibercept in the first go itself. Though I tend to use Pagenex or brolucizumab every now and then if I have to extend intervals in PCV. So that would be my take. I open it up to the panel again.
Okay. Thank you for
Doctor,
your
your choice of agent in PCV, your drug of choice, sorry.
You're asking me?
Diva sir. Divakan sir, sorry. Thank you,
Okay,
sir.
sure.
I think he's not there. Dr. Kaushik, are you there? Oh, he's
Dr.
also
Kaushik
not there.
had to leave for
Right.
something.
I think we can move to the next speaker. I would now invite Dr. Rashri Rawat ma'am to please share her screen and deliver her talk. Over to you, ma'am.
So, a very good evening to all of you. So, today I'm going to talk about two cases, CNVM in young age. Am I audible?
Yeah,
Yes,
ma'am.
yes, ma'am.
Yeah, okay, fine. So, today I'm going to discuss two cases, CNVM in young age, aflibercept case-based insights. So, my first case I have labeled as a notorious CNVM. Why? We will see later. So, this is a 40-year-old male who presented with diminution of vision in left eye for 1 month. He had a history of multiple intravit anti-VEGF ranibizumab elsewhere in the last 2 years. There was no loading dose given and none systemic or trauma or drug history was there. So my first thing was there, why there is a CNVM at the age of 38 year? Because he presented me at the age of 40 year. So looking at the fundus picture, he had a vision of 6, 18 and 6 and one can make out the scar of the previously could be a CNVM treated with the ranibizumab, and you can see the new activity here on the temporal side. Though the fovea was partly involved inferiorly, but it was spared superiorly. And keep watch on the superior to disc this lesion in the subsequent photographs. So looking at the OCT, that scar part, you can make out there is total atrophy of the choriocapillaries and outer retina here. And this is the active part of the CNVM that we all know that irregular fiber PD, SRF, IRF and SHRM was there. So I thought I will start with a 3 loading dose of ranibizumab here because he had a good response and vision was 6/18 as mentioned in the old documents. So I started with the first dose, a month later, second dose, and a third dose. Third dose I skipped because vision was 6/6 and there was no activity. So I have not given the third dose. And the next October, so after September, the 26th of the October, I have given the third dose 2 months later because there was the activity. A month later, again, I have repeated the fourth dose of ranibizumab. The vision was again 6/6 and there was no activity. Jan 2024, for I have advised the patient aflibercept because again there was the reactivity and this time the lesion was quite big and involving almost all the fovea. Keep a watch on the lesion here on the superior to disc. You can see some kind of the fuzziness, a small round patch was there. So at this point of the time, I started with the aflibercept and I have given the second dose aflibercept a month later. But after the 2 dose, again the vision was 6/9. There was the no activity. So I skipped the third loading dose here and I keep on observing for the next 2 months. On the same time, the lesion of the superior of the disc, it was becoming more bright. So 27th of the April, there was the activity, but patient have not taken the aflibercept because of the some financial consent. He was not granting his insurance. So on the 7th of the May, 2 weeks later, the almost after third month of the last second dose of the aflibercept, I have advised the aflibercept again, and vision was 6/24 at this point of the time. And the June 2024, a month later, again given the second dose of the aflibercept. In the July, the disease was quiet. I have not given the aflibercept here. Again in the August, the disease was quiet. So 3 months later from the last injections, again the vision dropped to the 6/60. And one can see here the brightness has been increasing superior to disc and the scar was progressing, though the superior part of the fovea was still spared. So then the successive visit keep on injecting the aflibercept. Still the scar was progressing inferior to fovea. The superior of the fovea was well spared. So I could extend the period of the aflibercept from 1 month to 3 months in between. But as I said, keep on injecting the aflibercept by extending the periods from 1 month to 3 months quiescence, no injections. In May 2025, when it was almost covering the whole of the fovea and crossing the fovea on the other side, I thought that I will give faricimab at this point of time so that I can reduce the scarring subfoveally a little bit and I could preserve the vision. So I have advised faricimab on 9th of May 2025. To my surprise, 19th of May, patients came back with drop of the vision, drastic drop of the vision 2/60. I mentioned it as a paradox worsening with the faricimab injections, waited for the 4 weeks, and 26th of the June again started with the aflibercept for 2 doses, and again I got a quiescent period of the 3 months. Then I again injected aflibercept on 10th of October 2025. Keep looking at the superior part of the disc. Now this lesion was well defined and quite similar that lesion near to the fovea, and one more lesions I got on the nasal side of the disc. In between, I also ordered for the ICG to look for the any hotspots at the multiple sites and the octa, but I couldn't get any hotspots or treatable laserable lesions here. So keep on injecting, and 26th of December, again, the drastic worsening of the disease. Vision dropped to the 6/60 on 10th Jan 2025. Injected aflibercept, almost a gap of the 2 months. And from that till 16th of the March, disease is quiescent. There is no activity, and I keep observing this patient. But to my surprise, these 2 lesions, I don't know when this will burst out, and again there would be activity on the other side, the fovea. And here I want to highlight 2 things. So I started the scar here, and over the period of time, this scar size was worsening, and it like crossing the fovea. And the 2 lesions, superior and nasal to disc. And if you look at the beside the subfoveal lesion, I want to make highlight here on the scar side. Here you can see the some part of the outer retina is still intact, but here you can see that everything has gone out. So my concerns here is it is unstable CNVM, visual fluctuations despite of the treatment, spread of the previous scar over the time, and now I'm quite worried that this scar, though its scar is forming below the fovea, superior part is still spare. But over the period of time, now I'm worried that scar will spread and it cover the superior part of the fovea, and vision will drop that will not be recoverable. Multiple tiny lesions here and there in the fundus. Favorable outcomes here are good anatomical and visual recovery is achievable with timely aflibercept. Retina is still responsive to anti-VEGF therapy despite chronicity. Still vision regained to functional level 6/12 range. Future concerns are here: how to prevent subfoveal scarring, vision drop, progression of the CNVM here. Treatment strategies: should I treat and extend, or should I do the fixed interval or PRN doses? Patient counseling for the treatment adherence and for the future drop in vision despite ongoing treatment. So that's why I labeled this case as a notorious CNVM. And then my second case, again, a 35-year-old female who presented to me with diminution of vision in left eye for the 6 months. She was on treatment for PCOD, and she has taken progesterone 300 milligram twice a day for 20 weeks during pregnancy. She was advised anti-VEGF elsewhere 6 months back, but she has not taken, and there was no history of trauma, infection, high refractive error. This was the fundus picture when she presented to me. I could clearly make out there was a subfoveal scar, and a membrane was there. On the both sides, there was a speck of heme was there. I look into the other fellow IOCT that was absolutely normal. One can make out the clear-cut choriocapillaries and outer retinal layers here. And this was the OCT of the left eye. So I started with the aflibercept here. The first dose was given on 23rd of the May 2023. Vision was 1/60. Also, I counseled the patient that I'm not expecting very much gain of the vision here because of this visible scar kind of thing here. But to my surprise, after the 3 injection, the vision has improved to 6/24 and 18. And the last injection was given on 30th of August 2023. And she is microbiologist by profession. She keep on moving from one place to another place. So this was the last visit to me with the vision 6/24 and 3 dose of aflibercept. So CNVM in young onset, always keep your focus on the different etiology. It could be pathological myopia, inflammatory disease, connective tissue disorder, structural, idiopathic, or traumatic, or pachychoroid spectrum. In this case, this 35-year-old lady, I have given one thought: could it be a progesterone or steroid that induces a CSR? Though it's not possible, or the fellow IOCT was quite normal, so I didn't encounter here any pachychoroid spectrum, so I label it as a idiopathic CNVM. better prognosis than the counterpart AMD, but still the early recognition and switchover whenever required will gain the good outcomes. Though the choice of drug matters, but sometimes the predictability of outcome varies, as we have seen in the first case. So thank you.
Thank you, ma'am. Those were very well documented cases. Uh, I would request Dr. Somil sir to please give his valuable comments.
Yeah, डॉक्टर दीपांशु, मैं इतना ही मेडिकल रेटना आंसर कर सकता है, इससे ज्यादा नहीं. And you're adding, I think in the first case there was some uveitic component in the mix.
Yeah,
And
yeah,
when uveitis starts, I completely get switched off. But I'll try to add something. See, the first case no was not definitely an idiopathic CNVM.
yeah,
You see the component of CNVM where it was more or less sub RP. It was spread in that uneven and manner around the fovea that you could see that scar inferiorly and you could see those multiple dots. So I think she didn't give the third injection at the correct time. She didn't give the first three injections at monthly intervals, thinking probably it's an idiopathic CNVM. You can wait for the third injection. I would have given that, and I would have followed treat and extend to the T, because the first case was not typically an idiopathic CNVM. The second case, I agree, was an out and out idiopathic CNVM. Most of the component of CNVM was subretinal rather than sub RP, and that would have really done well with a very routine, regimen of anti VEGF. So that's all. The first case ideally should have been worked up for some uveitic
yeah.
issue or something like that.
All right, sir. So your treatment, I was asking in the previous talk as well, your agent of choice, in if a treatment naive case comes to you between Vabysmo, brolucizumab and aflibercept.
So you are asking me this question?
Yeah, yeah, yeah.
So if it's a very typical type 2 CNVM or a classic CNVM or a subretinal component, which is not definitely, you know for a fact it's not the PCV kinds, I could give ranibizumab as the first agent of choice. And if I'm extending or if the treatment is resistant, then switch over to second generation. Primarily, that would be aflibercept. If the pathology was PCV to begin with, or a type 1 CNVM, a notorious CNVM which is sub RP primarily, to begin with, my first agent of choice would be aflibercept, unless the patient is not affording. Now we have biosimilars of aflibercept also. So my favorite go-to molecule was always Zaltrap, which though it's not a biosimilar and it's an off-label drug, but it worked wonders like aflibercept, and I could even vary the dosage. I could give in 4 milligrams, 6 milligrams, 8 milligrams. It's like it worked like a high dose aflibercept, or Eylea HD is what people are planning to launch. So for me, in PCV cases, aflibercept would be the first drug of choice. And in resistant cases, or if I needed to extend, time and again, maybe I would have switched to brolucizumab occasionally. Nowadays, I think I've had a lot of discussions with Kartike, and he's told me particularly to try a lot of Vabysmo in these type of conditions, especially the PCV ones. And I have tried now, and it has also worked well. But if I have to compare the two, I really don't know where I have to draw the line. There is still not that much of data which I can, really put my finger on. Get this should be my first line of choice. But yes, any second generation anti-VEGF would be my first drug of choice in cases of PCV, or any cases of uh, a, a a kind of CNVM that is
Resistant
not going to
cases.
behave itself. Yes.
All right. Thank you. Over to you, Dr. Nikhil.
Okay, thank you everyone for a wonderful session. Should I announce the winner, Dr. Karthike?
Yeah, you should.
Yeah, okay. So I think very well presented, all the Retina warriors, and I think it was a very close call. But congratulations once again, Dr. Giriraj, for winning the session. And I don't know if you're going to get an LPG cylinder or your car's gonna be fueled up. But yeah, congratulations once again. And I think everyone had really good cases to present. And I think we've learned a lot from all the expert panel. Thank you, Dr. Somil sir, for your insights, Dr. Devakant sir, Dr. Kaushik, Dr. Karthike, and Dr. Dipanshu, of course, and Dr. Richa and Dr. Rajshri for their wonderful cases. And thank you, Team Bayer, for organizing the session, and Neurotech team for doing the backup work, and all the participants, of course, for voting. And that's it. I think we can call it today. Dr. Karthike, do you want to add up anything? I think he's already
He
frozen.
is already
So,
frozen and asleep, I think.
yeah, I think he's very smart. He comes sharp at 9 and he
Yeah.
goes, he's back.
Yeah.
Okay. Yeah, so congratulations,
Yeah.
Dr. Giraj, and thank you,
Right, thank you.
everyone.
Thank you for organizing, and yeah,
Yeah,
good night.
wonderful session.
And to
Thank you for having me.
Yeah, thank you,
Thank you,
Samil,
thank
sir,
you so much.
really.
Samil sir, for coming.
Yeah, thank you, sir.
Bye.
Good night, everyone. Bye-bye.
Bye.
Bye. Good night.